Good evening, friends, and welcome to this Thursday evening teaching session brought to you from Lokmanya Tilak Municipal Medical College, Sion, Mumbai. And we once again thank the authorities at Sion Hospital for allowing us to conduct these classes. Today, again, we have a case presentation by Dr. Aditi Shah, followed by a small talk by Dr. Srinivasan sir from Pondicherry on approach to acyanotic congenital heart disease. So we'll start with the case first, Dr. Aditi Shah.
Good evening, everyone. I'm Dr. Aditi, and I'll be presenting the Thursday clinic case for today. 6-year, 8-month-old boy, second by birth order, born out of third-degree consanguineous marriage, resident of and hailing from Akola, Hindu by religion, Chambhar by community, was brought and informed by mother, who is reliable, with complaints of cough since 3 years, complaint of fever on and off since 3 years, and complaint of breathlessness since 2 years. The child was apparently all right till November 2020, that is 4 years of age, when he developed the first episode of fever, cough, along with paleness noticed by the mother. The cough was dry, non-spasmodic, not in bouts, associated with post-tussive vomiting. It was present throughout the day, exacerbated in lying down position and in the night, but not significantly disturbing sleep. It subsided on local cough syrups and on rest intermittently. Fever was mild to moderate grade, not associated with chills or rash, intermittent, subsided on local medications. Child was active in the interfebrile period. On investigations, the child was found to have a hemoglobin of around 5 and required blood transfusions. During the course of illness, the child has required multiple blood transfusions around 7 to 8 times, each time presenting with fever, cough, and paleness noticed by the mother. Last transfusion was in March 2022. The child would be admitted, transfused blood, and discharged, but never received any long-term medications or supplements on discharge. Then, since the last 2 years, the child developed breathlessness, initially on playing and running, which gradually progressed to breathlessness on walking short distances, to breathlessness on laughing out loud since the last 5 months, but has not progressed to breathlessness at rest. Last admission of the child was in March 2023 for breathlessness, where the child was extensively evaluated. A CT chest was done, and then the child was referred to our center for further workup. There was no history of hemoptysis, no history of Cox-Cox contact, no history of any known allergies, family history of asthma or repeated nebulizations, no history of cyanosis, pedal edema, palpitations, no history of rash, joint pain, no history of hematuria, no history of bleeding manifestations, no family history of gallstones, repeated transfusions, or jaundice. ANC and birth history, ANC registered, routine ANC visits done, supplements taken, no USG scans done, no ANC complications. It was a full-term normal vaginal delivery. Baby cried immediately after birth. Birth weight of 3.3 kg, no history of NICU stay. The child is immunized till 16 months as per the national immunization schedule. The child is developmentally normal for age, attained all milestones at appropriate age. Currently, dietary history, the child consumes all food groups equally, consumes a mixed diet, expected to observe calorie, a deficit of 100 kilocalories is present, and expected to observe proteins, deficit of 4 grams proteins is present. Family and socio-economic history, there is history of chula exposure at home, but no family history of such similar complaints or any chronic disease, no history of Cox in the family, and belongs to lower socio-economic class as per the modified Kuppuswamy scale.
So we'll first discuss the chief complaints. The first time that this child presented with fever and cough, right? That was at the age of 4 years. That was the first episode of fever and cough. How long did this illness last?
The child was apparently all right completely till 4 years of age. And then the child developed fever. Along with fever, there was cough. And over a period of 1 week, the mother noticed that the child was becoming pale.
So pre-illness, this child was not pale?
No. After the fever and then the child developed cough, then the mother noticed that the child was pale. Pre-illness, the child was not pale.
Okay. And the fever and cough lasted for how long?
They lasted for 1 week. Then once the child was admitted, he was transfused. After
Yeah,
that,
that
the
you
fever.
told. So what I'm trying to judge is, first is I'm trying to judge the chronology of fever, cough, and paleness. Second, I'm trying to judge the length of the illness. Because I mean, if a 4-year-old comes to you for fever and cough, what are your thoughts? First time when he comes to you.
Oh.
Yeah.
So just a simple fever and cough can be any upper respiratory tract infection if it's a short history even of 1 week for the first time.
Correct. So first is, like superficially looks like upper respiratory infection, but then do you want to get into some more details, or there are some things which are little odd, which don't seem to be fitting in? So normally when you have fever and cough, what else do you have along with that?
With fever and cough, the child might have increased work of breathing.
Not commonly, no. Fever, increased work of breathing is lower respiratory tract infection. What is that one word which is missing between fever and cough? Fever dash and cough.
Cold, cough.
Fever, cold and cough. So usually when there is no cold, still you say fever, cold and cough, and just now you are ignoring the cold. So is it important whether the cold is there or not there?
That could point towards a viral etiology.
So if there is a new onset cold along with this fever and cough, then it completes that picture of a viral. But if that cold is not there, then for a moment you are wondering whether is it a viral or is it something else? Because most virals would have a cold along with that cough. What else? So that's why I'm trying to dig into the chronology of that fever and cough, and how long it lasted, how long was the fever, if you have any details. So do you have any details, or?
So the details were like as told by the mother, lasting a week, and after the child would be admitted, transfused, child would
Correct.
get
So now next question is, child was admitted because of fever, because of cough, or because of paleness?
because of the paleness that the mother noticed.
Okay. So now what are your thoughts on fever and cough followed by paleness? So in this whole story, if the paleness made the child get admitted, then the paleness becomes the biggest issue. Fever and cough is sidelined. So now what are your thoughts on this paleness?
So it can also be that the child was pale initially, but the mother picked it up when the child got fever and cough because she looked into it more.
Okay. So it could be that the child was pale all along, and the fever and cough, the illness made her notice it all the more. Anything else? Suppose this was genuine paleness now, which was not there 7 days back. Then what does it mean? Who can become pale over a period of 5-7 days? Come on. I think bone marrow failure can become pale in 5-7 days, right? Huh?
Any autoimmune hemolytic.
So autoimmune or otherwise, but hemolysis. So one is a hemolysis can become pale. What else? Ongoing blood loss. Okay. So these are out of the various categories. Deficiency cannot become pale in 5-7 days. Bone marrow usually cannot become pale in 5-7 days. So those two classes are unlikely. So the class that remains is hemolytic disorder or bleeding somewhere. Bleeding can be obvious or hidden. So these are the categories that you have to think of. Now, can you connect fever cough with any of this? So can fever cough lead to hemolysis? Can fever cough lead to bleeding? Give examples of possible fever cough which can lead to hemolysis? Any infection that you know of? You are saying fever cough is an infection.
Mycoplasma.
Mycoplasma. So mycoplasma is known to be associated with a hemolytic anemia. So that's one example. What else? What about, you were saying autoimmune hemolytic anemia. So autoimmune hemolytic anemia is triggered by anything?
Hemolytic anemia. Drug induced could also be a cause for the hemolytic anemia.
Okay. So if some offending drug has been given for the fever and cough and which has triggered a hemolysis.
So
Then-
autoimmune hemolysis or just hemolysis? Other types of hemolysis. What you're saying is right. So drug-induced autoimmune hemolytic is one possibility. But as Dr. Rajesh is saying, it could be like a G6PD, right? So you have given some drug, patient has received some drugs and there has been hemolysis because of that, which is not necessarily autoimmune, but still hemolysis, as we are discussing intravascular or extravascular.
What about bleeding? So if it was obvious bleeding, then it should have become obvious. And if it is hidden occult bleeding, usually I would think the amount is very little occult bleeding. To cause pallor in 5-7 days looks a little unusual.
Unless we go back to the theory of acute on chronic situation where something has tipped the balance and now you are in the, now that it's been noticed. And as you said, either they have noticed it or somebody has pointed out. Many times they go to the nearby physician, doctor, some health worker who will point it out that your child's looking very pale.
Little bit of fever. 8 days of fever is not very short. How was the onset? Are you going to give much importance to this fever? Of course, because of a lot of the issue is getting into side track. But even if there is, suppose there was not much of the law, then when fever and cough is there for 8 days, you need to know. It's not a very short period. How high was fever? That was very fine amount of fever. What was it was high or said high little later. So some guesswork about what the fever could have been. And was the cough very significant? He used to cough sometimes. Fever was very mild. Then I think it was not something which was important. And then we'll start concentrating more on pallor. But fever was very high, 2 to 3 high spikes a day. First day it was low, then it was going on for 8 days. Cough was far active. Then this is not something where you are not going to look at even fever, cough, respiratory infections. So a little more attention to the fever and cough also.
I think two things. If you look at the fever and cough in this child, it appears that interfebrile period he was quite all right. And there was no other significant worsening. There was no cold. You said dry cough. So again, there was nothing possibly in the airways largely. Otherwise, it would have been a wet cough. And remaining for 8 days. So my first impression is it is the non-infective fever. Is the first impression. It's not a viral infection going on for a week. It's unlikely a bacterial infection. Respiratory, viral should have been with wet cough, cold. A bacterial should have been not much cough, but quick breathlessness coming up. So I started feeling that this was a non-infective problem. Okay, we may be wrong on that, but we keep that away. When it comes to pallor, always look at whether the history suggests acute or chronic or acute on chronic. Okay, we said acute would be hemolysis. So ask whether jaundice was noticed. Okay, when you ask them, they would say, yeah, I think there was a mild icterus. Then you have diagnosed hemolysis. But mild jaundice would not be picked up or would not be noticed by the parents unless we ask for it. So here it looks like that the child recovered, which means the paleness was noticed but was not acute. Had it been acute, Either it was an acute hemolytic jaundice with icterus, or any other acute severe anemia would have either come in shock or a cardiac failure. And this child did not proceed like that. So this child 100% has a chronic anemia. So you have, to my mind, a non-infective illness causing fever, cough, whatever, and you have a chronic anemia. Now you have a 4-year-old. Now in our country, 4-year-old can have a deficiency anemia also. But your diet is too good. Unless his diet is recently good. Yes. But I imagine diet is good. So this is not a deficiency anemia. So I'm looking at a chronic anemia at 4 years of age, and it's not deficiency anemia. Then what? Is it chronic hemolytic anemia? No. He may not have had jaundice, but would have had short stature or coming up early in life. So this is not hemolysis. Is it bone marrow? No, not bone marrow. So this is, to my history, suggests that it's a bleeding somewhere, and a bleeding that has not been noticed. Now put the cough into it. Is he bleeding in the respiratory tract? Is he bleeding in the interstitium of the lung? So is it any hemorrhagic disease in the lung going on for a long time? Okay. Because where can the chronic bleed occur? Commonest intestine? So we would have asked the history, whether there was any black-colored stool. Okay, might have given some idea, but it has not come forth. The point I'm making is negative history could have added jaundice, could have added black-colored stools. And how would you have thought of it if you would have started thinking of it while asking the history? Otherwise, we would not ask those histories. So the negative history has to be a thought-provoked negative history. Let's believe that he did not have black-colored stools, so he has no intestinal bleeding. He doesn't have an intracranial bleeding. He doesn't have an intra-abdominal bleeding. So it has to be an intra-lung parenchymal bleeding. And if we put all together, he has a chronic progressive blood loss in the lungs, manifesting with fever. What is fever? Some inflammation. And what is inflammation? Something that is destroying the cells. It may not be infection, it may not be great rheumatological, whatever. Had it not been pallor, then we could have pushed some more chronic rheumatological disorders of the lungs. But here is a pallor. So I think putting two together, my impression would have been a chronic bleed in the lungs, and that is obviously idiopathic. So, or maybe some idiopathic, but some vascular lesion which is bleeding. Yes, we will have to see later on an examination what it is. But I think that's the first analysis.
History of hemoptysis in that case would have been important.
The interstitial lung doesn't cough much. Interstitial lung comes with breathlessness.
Hemoptysis.
So hemoptysis may or may not come. Hemoptysis will come if the bleeder has got into the airway. But if the bleeder is in the interstitium, then there will be no hemoptysis. The bleeder has to come in a sizable amount into the airway for it to cough and bring out hemoptysis. So I still maintain largely, putting all together, this is just an imagination. And I think in this Thursday clinic, we are imagining how much in depth we go only by the history. Then we will see examination. And I'm sure you have presented cases where we have had no answer, even at the end of investigation. So we are not worried about being wrong. But I suppose what I've said looks logical, and I want any one of you to give some points against it, like Dr. Khare said. Now, any one of us can be wrong. I can be wrong at the end of 60 years. Okay, you should not be ashamed of being wrong. So if there is any suggestion, we are most welcome. But to me, this is the closest way of thinking.
So that's the
here-
reason.
Here the lesson to learn is that we have taken the point for analysis as pallor and not fever and cough. And therefore, it was a little more worthwhile going into, before disregarding the cough and fever, little more details about how significant. It is sometimes important to, out of 3-4 symptoms, it is sometimes important to pick up one symptom and analyze that. and that gives the way for further illness. So it is sometimes difficult to make out which symptom. If I take fever as a symptom, I'm going to get lost here. If I take cough as a fever,
More than lost, sir. So as you all rightly said, see, the pallor and the transfusion is hitting you. So you want to straight go to that. But when we discuss that mycoplasma can cause hemolysis, so that initial fever and cough should look like a mycoplasma infection. So your details have to will only tell you whether is it looking like a mycoplasma infection. So that's why we were asking right from the beginning, how long fever, what is the chronology, etc., etc. So as sir said, if this is non-infective fever, the characteristics of the fever, the sequence, everything would be a little different than an infection, and that is what you have to try and judge.
also it is difficult to analyze a case on first illness when you have heard so much about
Yeah.
follow-up also.
Correct.
So you have to completely disregard what you have heard later, and you are imagining that you are seeing a child with 8 days fever.
Okay, now
My point is, acute hemolytic anemia is never severe. Unless you have a G6PD and you
yeah,
have
and if
got a-
severe, it has to manifest immediately as a
Absolutely.
sick
And
child.
therefore, even if it is hemolytic, it should not have been complained by the parents. The acute immune hemolytic anemia, the parents don't complain of pallor. The doctor finds the pallor or an icterus. Because the paleness is not severe. In a child who has had normal hemoglobin, okay, if he has got a moderately low hemoglobin, he would look pale. I understand that. Okay. So when you gave that story and you gave the diet also, I still feel, of course, when you see the subsequent thing, it goes more in favor of what I've said. But even to begin with, I gave you a reason why I felt it is non-infective. I gave you a reason why pallor was chronic and not acute on chronic. And if it is chronic, it's not chronic hemolytic, it's not chronic bone marrow, so it has to be chronic hemorrhage. And if it's hemorrhage, not intestine, not intracranial, not intra-abdominal, so go back to lungs. I mean, to me, that looks, even on the first slide, a reasonable logical conclusion. Okay.
Now, when we rule out a bone marrow disease, one point we will keep in mind, that is megaloblastic. I just wanted to know, megaloblastic anemia can be deceptive and they can be, will it have become increasingly pale in 8 days? Because they can be significantly pale earlier and then it might manifest little later. So while we disregard bone marrow, and perhaps rightly so, one cause of bone marrow which we often may not think of is megaloblastic. Just keep it a back of.
But it's only megaloblastic. Why is there fever and cough?
Yeah.
That means we are dissociating two things. I want to bring both together. That's why we said it could be a chronic deficiency. On the top of it, something has happened. Agree. That is possible. But putting all in one, then we have to connect it to some immunological disorder. Anyway, I think we are open. It's good that we are differing, because, and finally, both of us can be wrong. Okay. And it doesn't matter whether we are wrong or wrong, but it's like a lawyer. Okay. Both the lawyers keep on fighting. We have been hearing about Maharashtra government having, okay, the decision comes after months, and that is also not acceptable.
So the issue is how to keep thinking about different angles, right and wrong, we will see. Now,
In fact,
for discussions, yes. sir.
deliberately, I want to bring out another point, whether I think of it or no, so that we have lateral thinking and we don't stop. Maybe sometimes the lateral thinking broadens our thinking. So whether you think of it or no, or whether you are agreeing with him, please think of some alternative so that the pros and cons are made out.
So now I think this child has got 7-8 transfusions so far on 7-8 occasions in a span of 2 years. Right? So now just focus on that and think and tell us whether what all is possible.
Before that, if you have any pattern in those 2 years for blood transfusion, then you can tell us. For example, the first 3 months required 3 transfusions, and then every 3 months he required, or whether there was first transfusion and then the second happened after many months. Because from what I hear, from March 22 to March 23 or May 23, there has been no transfusions, correct? So if
So
there is
there
any
is no
particular pattern.
specific pattern to the transfusions. Actually, over a period of 1 to 1.5 year, he has received 7 to 8 transfusions, like every
Equally,
alternate month.
more or less equally
Equally,
placed.
yes, or every alternate month, and every time the episodes would be like fever, cough, paleness, notice.
How many transfusions you said?
7 to 8 transfusions.
7 to 8 transfusions.
And the last transfusion was in March 2022. Since then, for 1 year, he has not been transfused.
Okay, so in approximately 22, 21 months, suppose you take 7 transfusions, is about once every 3 months. Okay.
So why did he ask for a pattern? What difference does he make? 7 transfusions in 2 years is anyway too much, no? Come on, what is the thinking? Who gets transfusions in a pattern?
Thalassemia, patients with thalassemia, they,
What is the pattern?
think, no, intervals.
Come on, try, think. You have to learn to speak.
Yeah, they
So
might,
regular.
They might get transfusions once, like it depends. Initially, they might get transfusions every 6 monthly or every yearly, and then
Thalassemia major, 6
No, not
monthly.
major. Major might get transfusions frequently, and then the frequency of transfusions might increase as it goes.
Why it increases? Why does the frequency of transfusion of thalassemia increase over time?
So like the iron overload pattern.
Come on.
bone marrow might less respond to production, मतलब less production होता है.
So by giving blood, bone marrow says, Abhi, you are giving blood anyway. Why should I
There
produce?
is
So I'll not
hematopoiesis.
produce.
It is inadequate
There is ineffective
hematopoiesis.
From the beginning. Yeah. It's inadequate from the beginning. Infection, why infection?
The question is, one reason is RBC life is small, right from beginning. What can add on to destroy RBCs?
Spleen, splenic destruction.
Hypersplenism. That is adding on, excellent.
Small life has become smaller.
Yes.
Okay.
Also, we have to remember normal RBC. What is the normal RBC span? 120. Brilliant. 120, right? So when you give a transfusion, it's always going to be less than 120 because that RBC has been produced already, stored, and then by the time you give it to the patient has already lost some days. So that also not for the decrease in frequency. We are not coming there.
In
Yes,
general, we are
in
saying.
general, normal RBC span, would you say 120? In a transfused RBC, the span is going to be lower than 120. That's what you have to mentally remember.
So
Then the question was, this was a regular transfusion. What can have a patient irregularly needing transfusion? So he has irregular hemolysis. Give a thought to that.
Sickle
Come
cell,
on.
somebody said?
who will get a transfusion sometimes once in 4 months, sometimes once in 8 months?
In case of sickle cell crisis,
Sickle cell. Okay.
Sickle may not need much frequent transfusion. So you're right. So give another thing.
So G6PD, whenever they're exposed to a drug,
P6PD if exposed to drug or
Yeah, drug induced. I don't take a drug for next 6 months, I don't have hemolysis. Yeah.
Or if I'm not given enough transfusion, required transfusion this time, then I may require transfusion quickly. But if I'm given good amount of transfusion, then maybe I'll require the next one later. Or maybe I required it at a particular time, but I did not come for transfusion. So these are the other non-medical sort of a reason for having irregular transfusions in a patient who otherwise requires regularly.
thal intermedia.
Thal intermedia. So can this be thal intermedia? 7 to 8 transfusions in 2 years. Forget fever and cough. Maybe he's getting infections because he's pale. No? Give us reasons why it is not thal intermedia. Think and tell us. Come on.
Age of onset,
Age of onset. Why age of onset?
so would have presented earlier.
And what is thal intermediate?
What is
I
the
know
new
major
word or the
combined.
correct word for it?
What is intermediate? Which means I'm not sure between the two. What is intermediate? What is intermediate? So there's nothing like intermediate really. Okay. It's a thalassemia major whose RBC life is not too bad to need every 3 or 4 weeks of transfusion, but maybe every 2-3 months of transfusion. Okay.
And some extra compensation by extramedullary hematopoiesis in these people, right? So what does that result in? As a result of that extramedullary hematopoiesis, what do these children have often? Very prominent
Hemolytic
hemolytic faces and hepatosplenomegaly. So abdominal distension, right? Okay.
Oh. As sir said, growth failure, right? Short stature or failure to thrive.
Should we move on? Yeah.
Was there, Dr. Mahesh is asking, was there any treatment given from March 22 to March 23? Well, you have written no long-term medications were on, right?
Yes, no treatment, no supplements.
Even-
He is
even in
wondering
last
why
1
last
year.
1 year no transfusion has been required.
So one of the reason could be that somebody started treating the disease. So that's what we wanted to check.
No.
No
No.
treatment.
Can we explain that?
What's your?
What is the explanation? It's not very easy to conceive this idea.
Hmm.
8 transfusions in 2 years and no transfusion 1
In
year.
the last 1 year.
So something has happened.
Hmm.
What could have happened?
So means mainly when I
If you know the answer, don't tell us that.
I don't know the answer, sir. But my first thought to this was maybe he was taking some medication in some form that would have helped in the interim.
So giving iron will help? Probably not,
Hmm.
because he would have received earlier 7-8 transfusion gives him so much of iron already.
Hmm.
So what could have really, I'm just thinking,
Hmm.
what was so bad and what suddenly became so good with apparently not much of change in the management.
Hmm. So maybe the course of the illness could have been a waxing and waning course. So it would have been that period. So
Difficult to imagine.
6-year, 8-month-old boy, birth and developmentally normal, partially immunized, with history of cough and progressive breathlessness, along with repeated blood transfusions in the past, is most likely a case of interstitial lung disease. To rule out pulmonary hemosiderosis, interstitial lung disease secondary to systemic autoimmune disorders of vasculitis, or Cox with nutritional anemia.
Okay, wait. So why did you put the third diagnosis?
So actually, he has received all these transfusions, but never received any supplements or hematinics. So then long term or even due to chronic disease, it could be there. And the other significant complaint of along with fever cough is the progressive breathlessness. So
No, that's so there are two parts to the third diagnosis, Cox with nutritional anemia. So we'll take both separately. So take Cox. So 2-year history of repeated episodes of fever and cough lasting say 7 days with gaps in between. And then after 1 year or 1.5 year breathlessness. That's the story. So can this be possible in Cox? For a time being, forget the anemia part. So can this be possible in Cox? So see, whenever we talk of Cox now as postgraduate students, let's talk of the organ and let's talk of the possible pathology. Let's not just talk of COX as a one whole, blob. So the symptom should correlate to the pathology. So what are the different types of pulmonary COX that you can get, in which you will get this kind of a symptom that you have to think, right? So fever and cough is possible in which pulmonary COX?
Like in primary.
Okay, so primary complex, progressive primary, all those, right? Now, in which of them he'll be fine in between for 2 months, for 1 year? Because he has fever, cough, then he's fine, then 1 month is fine, 2 months is fine, then again fever, cough. And which COX gets breathless? Which pathology gets breathless? Pulmonary pathology?
Like miliary COX scan.
Huh?
Miliary COX scan.
Miliary COX, correct. So now miliary COX, does it happen after a period of 1 year of struggling with fever, cough? Does it happen that way? In whom does miliary COX happen? Immunocompromised or malnourished child. So it starts as miliary. Right? It doesn't become miliary after 1 year of suffering from COX.
Yes.
Right? So therefore, this kind of a story doesn't fit into COX. Right? Now take the anemia part. So suppose somebody had iron deficiency anemia and he was so bad that he needed a blood transfusion. Will he need another blood transfusion in 2 months because of nutritional anemia?
Not just because of nutrition.
So unless he has a bleeding which has not been picked up, he is not going to need another transfusion. Right? So that is why that third diagnosis should not be offered only as a differential. Right?
One small point. Why do you want to call COX? Why not call tuberculosis? Call TB as TB. Is it a disease to be ashamed of? Not now. Okay, so call tuberculosis as tuberculosis. We have, with due respect to Robert Cox.
So the child has come. The child has come.
A child has come. We have
Any dietary restrictions that they have followed in last 1 year? No change in the diet pattern?
No.
Okay, we'll discuss further why. Anyway, till the child comes, why did I ask that question? In last 1 year, is there any change in the diet? I don't know if fava beans are available in Akola, okay? And nothing against Akola. Akola is a very sensitive matter right now. But I've never seen fava beans. So sorry. It's a well thought about. But the thing is, when you talk about pulmonary hemosiderosis or any inflammatory condition with hemorrhage in the lungs, celiac should also be considered because there is a strong association between the two. So that's why if there has been any dietary changes, then that sometimes can explain saying that your blood loss has been limited and you didn't require transfusion. That's just an outside thought.
Yeah.
So come, 2 volunteers to examine this child. Yeah. Come on, 2 volunteers to examine this child. Good, very good. Come.
You also stand there. Let the camera be 2 minutes.
You can come here.
So child, yes. On general physical examination, child looks well nourished and well built for a 4-year-old child, and he has pallor. Yes, sir. Akar.
Before that, before you make him do anything, first finish whatever you want to observe.
There is clubbing of nails, which is obvious. Otherwise, child is not breathless at this time.
Sure. Look at his mouth. Is his mouth closed or open?
And the nostrils.
See that? See that?
And then has to look at them.
Mildly tachypnic, but he's comfortable with the breathing.
Which means what? Chronic.
Like
What is the depth of the respiration? It's mild tachypnic,
mild.
but there is hardly any depth. Okay, he cannot compensate for the fast rate, and therefore he is not taking a deep breath. And then there is no respiratory distress. Okay, what does it mean? No respiratory distress, shallow breathing, bit shallow, not deep, normal maybe, mildly tachypnic. What does it mean when there is no respiratory distress? He's breathless, but no respiratory distress. Where is the anatomy of that breathlessness?
Then a parenchymal illness.
Okay, why not acidosis? No distress and tachypnea, no?
Deep.
Classically, huh?
It will be deep respiration.
Very good. So deep and rapid is acidosis. So if it is tachypnea without distress but not deep, then it is not acidosis.
Alkalosis. Shallow and fast. Any ICU registrar? I don't think there's depth.
No,
to
they
that.
won't be tachypnic basically.
Hyperventilating.
In alkalosis, there will be hyperventilation, but not.
See, we're talking of cause of alkalosis or effect of alkalosis. So Khare sir is asking, does this breathing mean that he is already alkalotic? No, if he is alkalotic, he wouldn't be tachypnic as a response to alkalosis. What you are talking of is short-term hyperventilation may wash out the CO2 and temporarily tip you to the alkalotic side.
Is his head large? Look at his mother. I thought his head is looking large.
It's normal. Breathing through mouth.
Breathing is there. His abdomen looks distended, sir. And
Mild subcostal retraction, very mild subcostal retraction, and he has little puffy face. Nose.
6 year old. 6 or 8 months old. Look at his length, overall appearance, and also don't forget to look at the arms.
He looks moderately malnourished.
Initially, you said well nourished, no?
Head circumference normal.
Huh? So he wouldn't be well nourished really. You can say averagely nourished is okay. He's not well nourished, nor is he badly malnourished. So he's averagely nourished. Okay. Fine. Now do the further examination.
There are no scars on the chest.
There is no knuckle hyperpigmentation, sir.
Okay.
He has clubbing and
So on the background of the history that we have got and whatever we analyzed, how do you explain this clubbing? He has a liver disease now, or a biliary disease, or a cyanotic heart disease. What does he have?
So he has the history of progressive breathlessness also. So that clubbing is a reflection of that chronic hypoxia.
Very good. But and anatomically, where is that hypoxia?
Means at the respiratory level, lung.
Yeah, but within the lung at the interstitial
Interstitial.
level. Go on, go on.
Why not a cyanotic heart? You have a cyanosis, you have clubbing, he is breathless. Cyanotic heart. We haven't examined his cardiovascular system. Cyanotic heart.
So there is no central or peripheral cyanosis. There is clubbing, but there is no central peripheral cyanosis. And
His palms look very unusually pink. Must be polycythemic.
his tongue is pale.
जीभ दिखा बेटा.
not much.
There's almost a dusky look to that pale and dusky combination. Anyway, go on.
There is no pedal edema.
Yeah, now start examining him. Give me the mic and start examining him.
Want to imagine before you start examining what are likely to be the findings? Gross respiratory findings, abdominal findings, heart findings.
Yeah, so far you are narrowing down on which system? History so far, examination so far. Respiratory or cardiac?
Clubbing is there. Cardiovascular might also be involved, sir.
Might also be involved. So now think which cardiovascular is possible. Think of the history also. So you are saying clubbing due to cyanosis. So cyanotic heart disease. Cyanotic heart disease which first manifests at 4 years of age. And he is now 6 years of age. So which cyanotic heart disease can fit into this age bracket?
Eisenmengerization.
Very good. So now is this story of Eisenmengerization, this child's story? So what is the standard story of Eisenmengerization?
It will present as an acyanotic disease in the infancy with breathlessness. And
So
failure to-
frequent episodes of cough, breathlessness, fever, then some reduction in those, and then a cyanosis, right? So this is not that story. So this is not Eisenmengerization. Can any acyanotic heart disease first present as Eisenmengerization? I'll make it easy, not in pediatrics. ASD can present as Eisenmengerization first in second, third decade, quiet in pediatrics. Okay. But generally, most of the ones which we see, no. So now Can it be a primarily cyanotic heart disease? Which cyanotic heart disease can present late?
TOF.
TOF. So pink fallows initially presenting later as at whatever age, right? So can this be TOF on your history?
So it is unlikely. There is no history of any cyanotic spell, no cyanosis on examination. Child is almost well built, average built, no failure to thrive. And
Yeah.
history of repeated transfusions, which
Yeah, so repeated transfusions of just throws away TOF. But about build and all, I mean, just because we are discussing, so the very fact that we are saying he was a pink fallows, that means he was well oxygenated for the first 3-4 years. His build may not be affected so much for you to make out clinically. That point is not there, but there are those other points.
I think whenever you have a cyanosis and clubbing, also look at which is more prominent, which is less prominent. In a typical cyanotic heart disease, you have a cyanosis there already, clubbing comes up over time, and therefore there is disproportionate. Of course, clubbing becomes much severe. Here, clubbing is say grade 2 or so. And a cyanosis, we have to look carefully to see that, yes, there is a little yellowish, bluish hue to it. So the clubbing is more prominent. Cyanosis looks to have come up later in the course. So we can kind of imagine that way. But look at the fallows, he's quite, how does a fallows history come up? Oh, he's blue. How is this story come? Oh, blueness is not seen by parents at all. And you start feeling a little hue, which is doubtful. And you are talking about anemia and cyanosis. Any comment on, can anemic child be cyanosed?
So he was cyanosed, but anemia concealed his cyanosis. He was cyanosed. And maybe, as we said, isomengerization becomes better. A child who is symptomatic, when he becomes isomengerized, there is transient decrease in the symptoms. He feels better because the shunt is reduced.
So what's the relation between anemia and cyanosis? Quick.
Sir, anemia does not manifest cyanosis because deoxygenated hemoglobin more than 5 gram to be present to manifest.
Very good. Okay, right. So we were saying whether this could be cardiac or respiratory. So now we have decided this is respiratory. So now, as sir always teaches us, anticipate findings. So now in respiratory, are you expecting this to be a airway disease?
No, sir.
No. So it could be interstitial disease or parenchymal disease. Can it be pleural disease?
Pleural will have pain.
Yeah, so this is not pleural, this is not airway. So you're between interstitial and parenchymal. So you're expecting findings unilaterally or bilaterally?
Bilateral.
Very good. So you are expecting bilateral findings. What findings are you expecting?
Like crepitations, Velcro crepitations.
Very good. So fine crepitations. Fine crepitations bilaterally are what you are looking for. Now, second, which sir already pointed out earlier, what are you expecting in an interstitial lung disease? Tachypnea is there. So what would you look at? The excursion of breathing. So respiratory movement you would check and say whether it's normal, abnormal, whatever. What else? Would you expect a dull note anywhere? No, you're not expecting a localized thing. You would expect a tympanic note anywhere? No.
Resonant.
Resonant. Yeah, general. There's nothing specific, hyper resonant or tympanic that you have. So you are looking for those fine crepitations bilaterally, and you are ensuring that there is no dull note or no localized finding anywhere. That's what you are looking for. Confirm.
Do you want to make him lie down? We ask him to remove his shirt. बोर कराएंगे आणखी मागून. He has a point. She says all respiratory system examination must be done in patient which is in sitting position.
इधर पे
Dr. Maniar, do they object to patient not being stripped up to waist in the examination?
I am no authority on it, but the general consensus is you always take permission, make sure that if it's a girl, child, female relative is along with you, or at least a female attendant is there along with you. If the child or the parent disagrees with it, then you say, I asked and whatever was possible, then I did it. Okay. But make sure that you ask that I would like to, if you're examining the chest, obviously that you would like to bear the patient and then examine.
Given a choice, would. You remember in one of the hospital OPDs, when the patient was lined up for a senior pediatrician to see, everybody was stripped up to waist in Wadia. You remember that? So remember?
I think what Tushar said is right, that we want to examine naked, but we may not be allowed. We must take permission, and you can do it gradually, isn't it? To begin with, you may not be fully naked. Only when it comes to seeing genitals, you ask for a permission, and I'm sure that is fine. But
Just about this.
yeah, I suppose that is quite all right.
Also, when you go to appear for your exams, make sure that you ask for screens as well. Okay. Make sure that you are at least not just show that you are sensitive, but be sensitive because it's useful throughout life. Okay. It's actually very disturbing to lie down on a bed, first of all, in front of people whom you don't know, or even in front of people whom you know. So imagine somebody asking you to open your dress and lying down. So it's uncomfortable. Also, one more thing, not only for this, but for other examination is when you present your findings, you present in a systematic manner. When you are examining on your own, not demonstrating a sign, don't go in systematic manner, right? So if I am seeing the oral cavity, I don't have to say that I'm going to do ENT examination later. Right now, I'm only seeing pallor. So I will make the patient open the mouth 3 times. That doesn't work. Or if you are examining the patient in prone position, whatever you want to examine, finish examining, including tone, power, etc., etc. And when you present it, present in a systematic manner, right? But if you are asked to demonstrate a particular examination, then you of course have to demonstrate in systematic manner.
The trachea appears central.
Hold it close, hold like this.
Trachea is central in position. Then chest expansion I checked. It's bilaterally equal. Then I'll check for sounds whether.
Go fast. You will not be wrong, believe me. If you're wrong, we'll miss it. You pause, then that means you are not sure. Then I'm paying more attention.
Resonant sound. Bilaterally resonant sounds.
If you percuss nicely, it should have been heard in the mic. If a character will percuss, you will be able to hear in the mic.
In exams, examiners, some of the examiners want a perfect way of examination. And where we often fault is percussion, for example. Percussion has to be this. Wrist must move. When you take a deep tendon reflex, the wrist must move. Okay, we are not used to that. In an examination, you remember to do this. But we keep on doing like this. Most of us can make out even otherwise, but I think that is the way. Or like when you test the coordination, you have to go this way. Okay, not just this way. Yeah. So some of those things are really important for some examiners. They are very, very stickler about the method of finding them, right?
Many a times there is a reason for it. What happens is we try to say this, why are you so particular? But as sir said, unless you do this movement, when you are checking coordination, it's not just hand and eye. The pronation, supination movement and the fineness of that determines your cerebellar prowess. So it's important to do it correctly. Same way when you do percussion, any other ways you will be able to hear it. And most of the time there won't be a problem. But if you do it correctly, then you will get the same sound every time. And then you will be able to compare better. So there's a reason for it having a particular method.
And don't forget the chronic isthmus. And maybe also on both clavicles without the finger being there.
In fact, when you percuss the right way, you can hear also the percussion sound. Okay. Even I can hear when you are percussing, because that is a tap. Okay. Yeah.
Chalo, speak. Acha, auscultation. Quick.
Since we are talking about examination, for abdominal examination, you normally ask the patient to fold their legs and then you examine so that the abdominal muscles are relaxed and you can see it. Now, if you do that for infants, then some examiners feel that why do you need to do that? They don't have a tense abdomen, and if you lift their knees up, then you don't have enough space to go in and work. So there are going to be some idiosyncrasies everywhere and you cannot do anything about it. But so far as you know the reason about it, you will not have an issue. As sir said about the isthmus or percussing on the clavicle, at least personally, I would be worried when I would be looking out for when I ask somebody to do it and then that person is doing or not. If you are examining the patient on your own, for this patient, for example, if you didn't check the isthmus, I don't think we'll bother. If it's an adolescent patient, adolescent kid or a teenager, good sized chest, then you will be able to appreciate different areas and you should be paying more attention.
If you are asked to examine the examination, looking at the technique rather than what are your findings.
Sir, normal vesicular breath sounds only I'm hearing, and inspiratory sound is equal to expiratory sound I'm hearing in this case.
Which means what?
Lung.
If inspiratory sound is equal to expiratory sound, it means what?
Because of pathology only, it might be hearing like that. Usually inspiratory sound will be like longer than the expiratory.
Correct. So if they are equal, has inspiratory sound become shorter or expiratory sound become longer? If expiratory sound has become longer, what does it mean?
Bronchial pathology.
So there is a subtle wheeze that is there, which is possible in interstitial lung disease, no?
Yes.
Right? Okay. What else? Findings? Nothing else.
Like when he presented, Krebs were there, but Abhi Krebs.
Today there are no Krebs. Okay. Fine. If we have any other findings positive other than what we have discussed so far?
So no, positive findings were the clubbing, and actually on presentation, bilateral chest expansion was reduced and bilaterally air entry was reduced in all areas. Nothing else significant. No organomegaly. Rest systemic examination is within normal limits.
Sorry, I'm just curious. How do you check for bilateral chest expansion reduced?
So means when we check in the supramammary, mammary, inframammary area, so means as much as we expect the.
What do you expect? That's what I'm saying. What do you expect?
Tushar is being difficult examiner.
No, I'm not being difficult. Again, just a disclaimer here. Contrary to popular belief, most examiners are nice and the aim of the examiner is to pass the candidate. Okay.
So the point is making is that in respiratory system, we always compare one side with the other. So whenever you are saying something is there on both sides, You have to be careful how to justify
A
that.
significant reduction for you to say that it is reduced.
And also, when you see the upper portion, it's not this, because there is no expansion. You put your hand this and see the excursion forward. And we are seeing the lower portion, then you put your, here if you put hand like that, you are not going to get anything. So put your hands like, breathe. Tell him, breathe, saas le lo, lambi saas le lo. I didn't hear any conversation between you and your patient. You have to explain to him what you want exactly him to do. Lambi saas le lo. And then you will be able to show the signs better.
In this child, one could have asked him to take a deep breath and see whether he can do it. He will not be able to do it. Then you convince the examiner, yes, he has a very shallow breathing. Okay. So I think the point that was made was, when bilaterally you have abnormality equal, examiner is bound to ask you, why do you call it abnormal? So you have to give some reason. You call it deep and rapid respiration in metabolic acidosis. The question is bilaterally symmetrical. So you say that as compared to average, he seemed to be breathing deep. That's it. So here he is breathing very shallow.
You know, classically, you will see these situations when you have a patient, say, for example, with GBS. So then you can say that because when I splint one set of muscles, the others are not performing adequately, or there is hypophonia, or the voice count is lower than expected, or single breath count is lower. Okay, again, there are no norms for single breath count, but what we are trying to say is that when there is symmetry, just get some more additional things to be sure that there is a decrease in the volume.
For example, we have never included in a clinical examination the difference between deep inspiration and deep expiration of a chest size. Okay. Because there are no standards. Because what we mean is exactly that, does the chest expand fully or cannot expand fully? But I suppose when you tell the examiner, that looks very shallow to me, and here it's easy, he can't take much of a deep breath.
Dr. Moite, our online faculty is asking what relevant CVS examination you must do in this child. We have discussed and differentiated between a respiratory and a cardiac disease. We've called it a respiratory disease. Now he's asking what relevant CVS examination.
He's asking which chronic respiratory disease also has a cardiac disease.
Or cardiac changes.
So the chronic respiratory disease can eventually lead to a right-sided heart failure.
Very good.
Pulmonary
So signs of
hypertension.
pulmonary hypertension. So he's saying look for signs of pulmonary hypertension. Okay. Okay. Fine. So now what is your summary of the diagnosis?
A 6-year, 8-month-old boy, birth and developmentally normal, partially immunized, with history of repeated blood transfusions, with progressive dyspnea and cough, with clubbing, is most likely a case of interstitial lung disease, most likely due to pulmonary hemosiderosis.
So, I mean, you did summarize, but we have always talked about summary, that you have to try and derive the diagnosis. So how will you derive? Means how will your 1 or 2 sentences of summary convey to the examiner that this child is getting hypoxic with time?
So like the history, the duration of the illness could have been mentioned here, like with progressive dyspnea over 2 years, to explain the chronicity of the illness, and like the findings of clubbing and like the respiratory system involvement, means chronic hypoxia eventually leading to that.
Okay. And what about the hematological part? So what sir discussed in the beginning, you have to discuss it like that, this child has come with recurrent, with history of needing recurrent blood transfusions. However, this history does not fit into a hemolytic anemia because The age of onset is at 4 years. He does not have abdominal distension to suggest hepatosplenomegaly. He does not have icterus. He does not have hemolytic phases. So it suggests a persistent ongoing blood loss, which is occult. And then you combine it with this progressive hypoxia and put the two together, and then therefore the possible diagnosis is this, right?
Yes.
We have each time been saying that put anatomy, pathology, etiology in order. So what is the anatomy? An interstitial disorder. Add adjectives. Chronic progressive interstitial lung disease. Okay. What's the pathology?
The bleeding. The bleeding.
Inflammation. There is fever,
bleeding
no?
and-
So inflammatory. But is it infective or non-infective? So
Non-infective.
non-infective. So chronic progressive interstitial lung disease, non-infective, inflammatory. Okay. With progressive breathlessness and pallor suggesting a hemochromatosis. Okay. Etiology? What's the etiology?
Sir, means just based on the history and examination, we cannot ascertain any etiology.
Likely idiopathic pulmonary
Yes, yes.
hemochromatosis, right? So third degree consanguinity you have. Other than that, it's idiopathic.
Idiopathic.
And lastly, the functional diagnosis. What is functional diagnosis? Is deteriorating. Okay. And as of he possibly doesn't have pulmonary hypertension, but if left to himself, he would go into pulmonary hypertension and acquire pulmonary. So functionally, he is deteriorating.
Yes.
Investigations.
So we have his past medical investigations from outside, where initially his HB on presentation was 5.2, and it was a microcytic hypochromic picture. An HPLC had been done from outside, which was negative. Even a 2D echo had been done, which was normal, and that time saturation was 80% on room air. These were his outside investigations. They had done an entire workup like ANA and P-ANCA, C-ANCA. All of that autoimmune workup was also negative. And last, when he had presented actually in March, the admission, that time his hemoglobin was 15. And they had done an HRCT, which was diffuse ground glass opacity in bilateral lung parenchyma. In his course in the ward, the child was kept under O2 by nasal prongs. His room air saturation was 88, 89 on presentation. On O2 by nasal prongs, it was 100%. We had sent investigations from outside, from our side. So the HB was 15.6 with hematocrit 45.8, counts 11,200 and 2 lakh platelets. The indices are mentioned. The PS picture was normocytic normochromic. Iron studies, serum iron was 66, which is low normal. TIBC was 284 and ferritin was 414. His routine functions, liver function, kidney function tests were normal. Urine routine microscopy was normal. And workup for tuberculosis was also negative. This was the X-ray on presentation. This is also means suggestive of bilateral diffuse opacities in in all quadrants. And then we had done an HRCT for the child. So the report was diffuse ground glass opacity noted involving bilateral lung parenchyma with multiple tiny ill-defined ground glass density nodules scattered throughout bilateral lung parenchyma. Smooth interlobular septal thickening in apical segment of right upper lobe and apico-posterior segment of left upper lobe. These features likely suggestive of pulmonary alveolar hemosiderosis with superimposed early pulmonary edema, and their advice for a bronchoscopy and BAL. So the child underwent a BAL procedure, which was uneventful. The sample has been sent for Prussian blue stain for hemosiderin-laden macrophages. He has been started on steroids, TAP prednisolone 1 mkd. Symptomatically has improved over 8 days. Currently, room air saturation is 95%.
So he has iron deficiency anemia, right?
So like...
Yeah, serum iron is low. He has iron deficiency anemia. And we were talking about no deficiency anemia. We approved iron deficiency anemia, no? So must look for hookworms. Don't you agree? It's a chronic iron deficiency anemia.
It won't be that significant to need transfusions.
Why serum iron is low? Okay.
Once again,
Yeah.
This is the current serum iron studies.
what's the hallmark of iron deficiency anemia?
So ferritin is normal.
Ferritin.
Ferritin is specific for it, but I don't think here we can count that because ferritin would be high in inflammatory conditions.
Inflammatory.
So I think we would look at transferrin saturation
And
probably.
TIBC.
TIBC, which is also not elevated.
Yeah.
And so the HB also currently is
Serum iron, so
15.8.
Probably has nutritional. That could be because of any of chronic hypoxia. That could be a stimulus for a stimulator for
The-
erythropoietin. So that would explain the HB, but then otherwise probably the dietary history, like the diet wise, the child would not be consuming iron.
Chronic.
Iron has been converted to hemosiderin. I don't know.
It's certainly a continuous bleeding that the commonest cause of iron deficiency anemia at other age groups is a slow occurring bleeding,
Bleeding.
blood loss. So it's a blood loss, but there are enough biochemical parameters to say it's not deficiency. She talked about all those, right?
What is hemochromatosis? What is the difference between hemosiderosis and hemochromatosis? Or they are identical terms? Second MBBS, so it's many years that fewer years for you. As far as I remember, it's hemosiderosis is deposition of iron in a tissue, and hemochromatosis means associated inflammatory and degenerative changes in the tissue, which is the next stage of hemosiderosis. Correct me if I'm wrong after seeing the link.
Hemochromatosis is a damaged cell.
Damaged
Hemosiderosis is
liver.
iron is getting deposited.
Hmm.
So in the liver, typically this happens, hemosiderosis or hemochromatosis. Because if the cells are damaged, then there's going to be a progressive cirrhosis, for example, there.
Can it be Goodpasture syndrome? He is vomiting, but he has no hemoptysis and iron.
By
And
now the renal
so
function.
slow blood loss. What are the causes of hemoptysis in children in order of occurrence? Because hemoptysis doesn't occur much in children.
Bleeding disorder. Yes or no? Come on, yes or no? So bleeding disorder is not a cause of hemoptysis.
Yeah, bronchiectasis, pneumonia, foreign body,
Bronchitis, foreign.
bronchoscopy, hemochromatosis, hemosiderosis are in that order respiratory causes of hemoptysis. You can have a cardiac cause also due to hemoptysis. Okay.
Okay, thank you. Okay, so now we start with the second part of the class today. Srinivasan sir.
Yes, sir. Can you hear me?
Yes, sir, we can hear you.
Yeah.
Sir, you can start.
Thank you. Very well discussed. The interstitial lung disease, hemochromatosis.
Sir, just 1 minute.
Yeah, I am ready, sir. Whenever you are ready, please tell me. Can you hear me well?
Yeah, we can hear you.
Yeah. I am ready. Yeah, can you make it full screen? Thank you.
ठीक है.
So can I start, sir?
Yes, sir.
Yeah. Thank you very much for this opportunity. I'll start with some 3 cases which I had seen during my post-graduation day. So this child was a 3-year-old male child, came, suddenly had a syncope and came, and that was admitted in Maulana Azhar Medical College when I was doing MD. And child was anemic as the previous case, but child's pulse was feeble. So what is the possible likely diagnosis? So naturally anemia, the child was not in failure. So we auscultated the child was having a ejection systolic murmur and aortic stenosis, and the pulse was slow, tardive pulse, anecdotic pulse. So I had diagnosed as a possible this thing, and then I auscultated in the aortic area. There was ejection systolic murmur, and also it was conducted in the carotids. And then the child was taken to GB Pant Hospital, which was associated the hospital with Maulana Azhar Medical College, and immediately workup was done, and child operation was done, because those days balloon angioplasty was not there. Similarly, another short girl had come, and the child was having no webbing of fingers, but there was the decubitus, and the child was having a murmur in the pulmonary area, systolic murmur. And this child was having, we suspected pulmonary stenosis, and the child, of course, turned out to be pulmonary stenosis. Subsequently, the child was then chromosomal workup, and the child had a Turner syndrome. But there was no webbing at that time, but this incubatus valgus was there. But short, so it's very important. Another child I remember where the child was taller than the normal, but very lean and bony. And of course, there was no subluxation of the eyes. I am giving you a clue. And this child had a murmur in the aortic area, and it's a ejection systolic murmur. There was no early diastolic murmur, but child was this thing, and then the upper segment, lower segment was abnormal. So, and then we did the thumb sign and wrist sign, and the child was having long, thin fingers. It's an early case of Marfan syndrome, which was diagnosed as early as 4 years. So with that clinical scenarios, I will come to the basic approach. Okay. So we have to look and observe the child. So we have to keep the eyes open. Very important. As a child walks in, or as a child is being seen, you must immediately observe the child, how the child is, the stature of the child, age and this thing, weight and height are appropriate. If the child malnourished or obese, a child is looking taller or shorter for the age. These are very important. So keep the eyes open and examine thoroughly. So right from the time the child is walking in, you must observe the child, especially if you are in practice. Ears, listen patiently to what mothers and parents have to tell about the child. Never ask open-ended questions, and ask them to tell, because they usually give the diagnosis. Proper history taking will give definitive diagnosis, and about 50% of the diagnosis will be given by appropriate history taking. So another important thing, I have in Mahatma Gandhi Medical College, I have been a teacher, and I asked them to display their cell phones, mobile phones, and the cost of the mobile phones, they have to keep the table. But I will also ask them to keep the stethoscope. Stethoscope will be very cheap one, but the mobile phones will be cost, about 15,000, 18,000, 20,000. So the importance given to stethoscope is not that much as it is being given. Of course, nowadays you can say everything is available in this thing, So that is different, but very good stethoscope is very important, that conducts the sound appropriately to your ears. Okay. Then hands is very important. Gentle touch to elicit various palpatory signs, pulses, as I mentioned in this child. Yeah, please. As I mentioned in this previous child, it's very important that you feel the hands and the warmth of the hands and feet. So many a times you find that we always touch this. I always tell you, keep your hands both on the both sides of the precordium. That way you will not mix any case of dextrocardia. I have given to my postgraduate some tricky case scenarios of dextrocardia. I will ask them, when they think they know everything, I ask them, when the dextrocardia comes, I ask them, you examine the child. But many a times these people fail because that is one thing. Whenever you are examining the precordium, keep both your palms on both sides, then you will be able to guess probably the child is having dextrocardia, then you can feel the liver spleen. Similarly, feel the, as we touch the elder's feet, it's our custom. Always touch the feet of the child and look for the dorsalis pedis. If the dorsalis pedis is very well felt, then if the child is having, then it's possible that the circulation is very good and you may have to think of a ductus arteriosus and other conditions which are having increased blood flow. But if the child is having little cold extremities and compared to the upper hands and the dorsalis pedis less, you have to think of an aortic stenosis. So it's very important that touch the precordium with both hands and see, that way you may not miss a case of occasional case of dextrocardia. Similarly, feel all the apical peripheral pulses and start with dorsalis pedis. It's not necessary that we have to touch only elders' feet. We can touch also child's feet as a mark of respect as well as for getting their cooperation. Then speech. Talk politely with empathy is very important, and each and every sentence, just now, of course, Dr. Tushar Mania has mentioned how you have to be polite and then ask the child, to be undressed, etc., in front of such a crowd. And so such things are very important. So, and also counseling is very important. Once you find the diagnosis, why you have to do such investigations, etc. And then, of course, after accumulating just now in the previous case, which you have discussed, you analyzed each and every aspect, correlated the history and the examination findings to arrive at a most probable diagnosis, which you have done just now. You have come to interstitial lung disease and then you have diagnosed it as a hemosiderosis because of anemia, etc. Next one. The asymptomatic child adolescent incidentally detected murmur, clinical presentation. Symptomatic infant child, time of onset, speed of progression of symptoms. So child can be asymptomatic, okay, incidentally detected murmur. So that is very common. So similarly, symptomatic infant child, time of onset, speed of progression of symptom is very important. Degree of functional limitation of symptom is very important. Why I am stressing on this? Many a times we have been attending webinar classes in various platforms, and repeatedly we tell, see, the pediatrics definition is, we are talking about a branch of medicine dealing with children from the time of onset, from the time of conception till the time of completion of adolescence, marking the linear height. Okay, that's very important. So naturally, growth and development and functional impact of the disease process on the child. Many a times they don't mention whether the child is having school absenteeism, etc., and how often the child is able to sleep, etc., how many times they wake up, etc. And it's very important, especially the child is having a left heart failure. The child will wake up suddenly, as you know, paroxysmal nocturnal dyspnea, etc. So sometimes they will have congenital mitral stenosis. So functional limitation of symptoms will be properly acquired. Daily activities, locomotor functions, feeding and sleep patterns should be mentioned in the examination when it's a long case. And growth and development is very, very important because we are talking about a child growing. So naturally, how that most of them they present as failure to thrive. Just now I mentioned a case where the child was taller than normal and lean, but there was no subluxation of the lens, but the child turned out to be Marfan syndrome with a wrist sign, as well as the child was canned. They think is very important, but subluxation of lens was not there at that time, but child had aortic stenosis, not aortic regurgitation. Next slide, please. Of course, this Nada's criteria, major and minor. So systolic murmur, grade 3 or more in intensity. Presence of diastolic murmur is always abnormal. Presence of cyanosis is very important to recognize. And of course, just now the question was asked, when there is anemia, how will you recognize cyanosis? What is the percentage of, she answered very well. And congestive heart failure, major symptoms is very important. Major criteria and minor criteria, systolic murmur 2 or less, abnormal S2, very important, especially with regard to diagnosis of ASD, etc., and also pulmonary stenosis, etc. Similarly, abnormal blood pressure. It is very important that we take blood pressure in all the 4 limbs to recognize coarctation of aorta. Again, I remember a case when the child was in the OPD, the upper limbs are warm and this thing. I asked, child was having an inguinal hernia, the boy, and then I asked them to touch But when they are examining that peripheral, the femoral pulse was very weak when compared to that, child turned out to be a correctation of aorta. So BP is to be taken in all the four limbs, at least right upper limb and left upper limb. That also I remember a case. The child had a pulse which was jerky in the right hand, right radial pulse. Left hand, the radial pulse was not that jerky. And then we took the blood pressure, systolic blood pressure was more in the right upper limb. And it was more than 10 millimeters difference was there. It was less in the left upper limb. And the child, we saw the features of Williams syndrome was there. Child was having a upturned nose, and also upper lip was very prominent, nose was very prominent, and turned out to be a case of supravalvular aortic stenosis. So it's very important that you take these observations, and of course, radiological investigation and ECG are very important in correlating and coming to a definitive diagnosis. So here, NADA's criteria, one major or two minor, indicates a heart disease. Next slide, please. Congenital heart diseases prevalence, of course, most of 3 to 8 per thousand live births. And incidence is more in the second pregnancy. So there is a chance of 2 or 3, 3 times, 2 to 3 times, there is more chance of another child having the same cardiac disease, congenital heart disease. Very important that you have a pedigree chart. Very important. Not only from genetic point of view, there are so many genetic syndromes, trisomies, etc., which will have cardiac disease. I just now mentioned about Turner syndrome. So it's very important that you take a pedigree chart. Then critical congenital heart disease, 3 per thousand live births, majority newborn period. Of course, they also mentioned the stillborns, the cause is 3 to 4% spontaneous abortus. When they analyze, they have found 1/4 of them may have a heart disease. Next slide, please. So this is how we usually, all of us know that congenital heart disease, we usually categorize as cyanotic and cyanotic by the presence of cyanosis or absence of cyanosis. Of course, we have to take into consideration the hemoglobin level, and we have to do pulse oximetry to confirm that. It's also part of a regular examination now, pulse oximetry. And then, of course, acyanotic left to right shunts are more common in children than obstructive lesions. And obstructive lesions, of course, if you examine very carefully, you may be able to find out some obstructive lesions may be occurring a little later on, and it can be miscellaneous. Next slide, please. So, acyanotic heart diseases, left to right shunt, pre-tricuspid is very important. Okay. Atrial septal defect, ostium primum defect, of course, has both this thing, pre-tricuspid and post-tricuspid, because there can be endocardial cushion defect and VSD. Then obstructive lesion, left side obstructive lesions, right side obstructive lesion. Just now I mentioned the case of pulmonary stenosis in a girl and turned out to be a Turner syndrome, and another child who had a valvular aortic stenosis in a 3-year-old boy with anemia having a anacrotic pulse. Miscellaneous other valvular lesions, cardiomyopathies must be considered whenever there is no murmur and there is a cardiomegaly and the child is in failure, which is unexplained. And of course, the other day also Dr. Amdekar has mentioned about the nutritional deficiencies causing problem, and the vitamin D deficiency causing pericardial effusion and cardiomyopathy as mentioned, if I remember correctly, in the last week or the previous week. Coronary anomalies, especially when the child presents as a dilated cardiomyopathy with no findings, you have to think of alpha, So Al-Kappa, very important. We had earlier seen a child in Maulana Azad presenting as a cardiomyopathy-like picture, and child was having evidence of Al-Kappa, and of course, child was operated upon. It's a treatable condition. So whenever child comes with severe myocardial pain, or child is having cardiomyopathy, dilated cardiomyopathy, you have to think of Al-Kappa as a possibility. And corrected TGA is not that common. Next one. So algorithmic approach, most of you will confirm. Clinical history suggests you have congenital heart disease. You know how you would take history in a child with congenital cardiac disease because of symptoms which you already mentioned. No cyanosis because we are talking about acyanotic heart disease. Confirm with oxygen saturation. I already mentioned that. Symptoms and signs of heart failure present or not present. If it is present, then we have to find out whether there is audible murmur. Usually, children with pre-tricuspid shunts will not have failure very early in life. But of course, if the child after the pulmonary arterial muscular regression, the child will accommodate more blood. So large VSDs and post-tricuspid, they will present from late infancy. Whereas pre-tricuspid, they will present a failure only after about 5 to 6 years, and the growth will not be affected. So you have to look for audible murmur. If it is yes, post-tricuspid shunts have to be considered. And then atrioventricular septal defect complete. Of course, you have to look for Marfan syndrome, Down syndrome. And as I mentioned, you have to always look for genetic predisposition. Then severe mitral or tricuspid regurgitation, which can occur due to abnormal valve. Severe aortic stenosis. Just now I mentioned a case of a 3-year-old child coming with syncope and anemia, but having anacrotic pulse, turned out to be a case of valvular stenosis. Then if there is no murmur, then we have to think of Alcapa or myocarditis, cardiomyopathies. Just now I mentioned vitamin D deficiency also can cause cardiomyopathy, can present as acute cardiac failure. So it's very important we think of nutritional cause also. And beriberi can present as pulmonary hypertension in a child, and it is immediately responds. Similarly, it can present as wet beriberi. They will respond very well to B1 administration. So now symptoms and signs of heart failure is not present, then we have to think of pre-tricuspid shunts, ASD. Of course, ostium primum is not one of them. And small to moderate post-tricuspid shunts also will not present as cardiac failure. Next one. History of symptoms suggestive of increased pulmonary blood flow. So whenever there is increased pulmonary blood flow, that means there is shunt lesion. Clinical examination suggestive of left ventricular hypertrophy. Naturally, you know how to examine and know the left ventricular impulse. Okay, or combined ventricular hypertrophy, there is both epigastric pulsations and parasternal heave. And as well as the child is having a left ventricular apical impulse, we have to think of biventricular hypertrophy. So initially, we'll think of VSD, that is the commonest among the cardiac diseases. Next is ductus arteriosus and AV canal defects. But if the child is definitely having right ventricular lift, epigastric pulsation, parasternal lifting, and also you find that this thing, fixed white split, then you have to think of ostium secundum ASD and left right shunt with pulmonary arterial hypertension. Okay, that is of course late evidence of Eisenmenger syndrome. If there is normal pulmonary blood flow, if there is right ventricular hypertrophy, pulmonary stenosis and mitral stenosis have to be considered, severe mitral stenosis. And if there is LVH, we have to think of mitral regurgitation, aortic stenosis, coarctation, and cardiomyopathy. So these are the ways you have to logically think and then come to a diagnosis, clinical diagnosis, of course, to be confirmed later by the appropriate investigations. Of course, now echocardiography is the most important investigation which can diagnose most of these conditions, even in utero. So if proper ultrasonography has been done, many of these conditions can be in late trimester ultrasonography, one must be able to pick up. Next one. What are the symptoms in left to right shunts? You know that features will increase pulmonary flow or failure to thrive. Interrupted feeds, all of you know, you mention every time you mention a child with VSD presenting at 6 months of age, 7 months of age. Delayed milestones also may be there now in some of the children. Excessive sweating is very important, forehead sweating. That of course we have seen. Mother always tells the whole pillow gets wet. Okay, and even when the child is in AC room, the child is sweating. So it is very important to remember. Chest distractions and fast breathing. Just now you mentioned about chest distraction, fast breathing without any specific lung, this thing. So it's very important that you find chest distraction, fast breathing. The child may not be having severe failure, but early failure may be indicative of that. So whenever there is chest retraction, fast breathing, think of your child with left to right shunt. Frequent lower respiratory tract infection will be present from 6 to 8 months of age, and prominent precordial activity which you'll be able to see. Yes. Of course, the modified Ross heart failure classification is asked in the examination. So this slide mentions, NYHA is no longer expected by the pediatrician. They always ask, I attended some of these classes. Many of them ask Ross classification, functional classification. Class 1 is no limitation of symptoms. Class 2, infants, mild tachypnea or diaphoresis with feeding difficulty. Older children, mild to moderate dyspnea on exertion. Class 3 is infant growth failure. That's what I mentioned. Growth is very important. And growth failure and marked tachypnea or diaphoresis with feeding difficulty. Older children, marked dyspnea on exertion, especially climbing upstairs. That's why you have to ask whether the child is able to climb to the first floor in the school, etc. Many a times they will say child is hanging. We have seen a child who had not able to climb up to the second floor in the school, and he wanted to come to this thing, but he had the claudication. It was a child with coarctation of aorta. Whenever child is having cough pain and not able to climb up or walk for a long distance, then you have to think of and then take blood pressure for all the limbs. Then class 4, unable to carry out any physical activity according to NYHA classification, but Ross classification children is symptoms at rest as tachypnea, retractions, grunting, or diaphoresis. Next slide, please. I have another 15 minutes, sir. So prenatal history is very important. Consanguinity is very important because most of the conditions are having genetic defects. So nowadays, more genes are being discovered to be cause of various congenital heart diseases. And there is a chapter in PG textbook of pediatrics on genetic aspects of congenital heart disease. Very well written by daughter of, I was a DNB examiner in Calcutta. So she is daughter of Dr. Khalilullah and my senior resident in Maulana Azhar. And so she has written a wonderful, you can read that chapter. So genetic workup is very important because we can predict and also look for possibility of other children being affected in subsequent pregnancy. Age of parents is very important, as you know, in Down syndrome. Maternal illnesses, intrauterine infection, all of you invariably ask rubella, etc. Diabetes mellitus as a cause of cardiac problem, especially cardiomyopathy. Hypertrophic cardiomyopathy is very common. And VSD, septal hypertrophy, then pulmonary stenosis, PDA, TGA, all these things can occur. And SLE, congenital heart block, phenylketonuria can be there. If the mother is having phenylketonuria, the child can have tetralogy of Fallot, or they can have VSD, ASD, PDA. So it's very important that we ask for history of metabolic, inborn errors of metabolism, diabetes mellitus, etc. Next. Of course, maternal dietetic history is also very important. As I mentioned, beriberi can occur very early in life if the mother's diet is very poor. And similarly, dilated cardiomyopathy can occur in a child whose mother is breastfeeding and not giving, her vitamin D level is low. They can also have cardiomyopathy very early in life. Prenatal history, as I just now mentioned, dietary nutrition history of mother, micronutrient intake is very important. These are two things which are to be considered, especially when a child is having unexplained cardiomegaly. Think of vitamin deficiency, and also in unexplained pulmonary hypertension and cardiac failure, think of vitamin B1 deficiency. And they respond dramatically, and many more cases are being reported nowadays. Maternal medications are very important cause of in pregnancy, and all of you know about these conditions. Sodium valproate, phenytoin causing pulmonary stenosis, aortic stenosis, etc. Lithium, of course, everybody will tell Epstein's anomaly and trichotillomania. Marijuana, of course, is nowadays coming in a bigger way in adolescence. Antitussive is also important. ASD, sex hormones, VSD, TGA, TOF. Alcohol, of course, congenital alcohol syndrome, you know that. Maternal smoking, prematurity, and PD. Next one. So, very important prenatal history. Family history and family pedigree chart. As I mentioned, genetic risk is very much there. Overall risk 0.8 to 4%. First degree relatives of patients with left-sided congenital heart disease 8 to 19% risk. Hypoplastic left heart syndrome 19.3%, and coarctation rate 9.4%. These are statistics which have been collated from various studies. Essential to be documented as there are increasing number of genetically predisposed congenital heart disease and syndrome. So it's very important that the examiners will expect you to write the pedigree chart for 3 generations. Next one. So left to right shunts, what are the clinical features? All of you know, increased pulmonary blood flow, there will be failure to thrive, interrupted feeds, suck, rest, suck cycle. I already shown this slide again earlier. Excessive brow sweating, chest retractions, false breathing, frequent lower respiratory tract infections, prominent precordial activity. Yes, this is a repetition, but it's worth seeing again. What are the causes of congenital heart failure in asymptomatic heart disease? Most of you will be knowing that at birth, severe tricuspid regurgitation, severe pulmonary regurgitation, large AV fistula. First week, ductus arteriosus preterms. That's why preterm immediately they try to close the ductus arteriosus. Critical aortic stenosis can occur in the first week. Critical pulmonary stenosis and critical coarctation of aorta. These are all ductus dependent conditions. So we have to give prostaglandin infusion. First month, coarctation of aorta, atrioventricular communication defect, large VSD, large PDA, and 4 to 6 weeks, large VSD. 6 weeks to 6 months, VSD, PDA, atrioventricular canal defect, and Alcapa. 6 months to 1 year, VSD and atrioventricular canal defect. Okay, these are all to be always remembered, and I'm sure you must be seeing enough cases in the 3 years of training. Next. Obstructive lesion. Just now I mentioned how I have seen a case of aortic stenosis in a 3-year-old child boy who was operated and saved. Those days, balloon angioplasty was done when I did 74, 76 in Maulana Azhar. Okay, child was. And similarly, pulmonary stenosis is not uncommon. So kindly remember, so they can present in neonates obstructive lesions very severe as shock. That's why we give prostaglandin infusion or heart failure. And infancy and childhood asymptomatic, most of them. External dyspnea may be there, effort intolerance will be there. Older children, adults, asymptomatic, same conditions. Angina in addition may be there. Then of course you have to look for evidence of cardiomyopathy. And also Alcapa must be considered as a possibility. Syncope, pre-syncope, I mentioned just a child, a 3-year-old child coming with syncope, very unusual. And so always feel the pulse very carefully and take the blood pressure carefully in all the limbs. Symptoms related to complications like bacterial endocarditis, cardiac failure, etc. Next. So genetic conditions, you see Holt-Oram syndrome, okay, and then Ellis-Van-Creveld syndrome and various chromosomal Down syndrome, and then the Turner syndrome, as I mentioned, and this child is having a cleft palate, etc. These are all trisomies. So chromosomal trisomies, as well as in whenever you find a thumb defect, you look for ASD. Similarly, if you find a clinodactyly, only there may be clinodactyly, you look for evidence of VSD. So short, you may not be having other features of Down syndrome. So finger is a very important index because the particular septum is also formed at the same time this particular limb is formed, this finger is formed. That is a correlation between these two conditions. Now, thumb anomalies and radial anomalies with ASD and also ulnar anomalies with VSD. Next one. So Ellis-Van-Creveld syndrome, there will be a common atrium. Cornelia de syndrome, they have various cardiac manifestations, congenital heart disease, and of course, these are all syndromes which you might have already seen. Okay, and of course, we had a case in Safdarjung Hospital DNB exam, Kabuki syndrome. Child was a case of tetralogy of Fallot, and similar Alagille syndrome also was kept with cholestasis and evidence of tetralogy of Fallot. So you have to look inborn metabolism as well as other conditions. Next one. Other points in general examination is failure to thrive. We have mentioned nutritional deficiency and growth faltering has to be considered. And if the mother brings a particular growth chart, you must look at it. At what time the child started having growth faltering. Then skeletal abnormality, just now I mentioned, even a clinodactyly may indicate a VSD, presence of VSD, or abnormal thumb or bifid thumb may also indicate or radial abnormality, ASD. Then spine for sacral dimples, spina bifida, kyphoscoliosis, especially Marfan syndrome. Examine for visceral situs, cardiac location. Don't take it for granted. That's why I told you always keep the hands on both sides of the precordium so that you will not miss any case of dextrocardia. Then, of course, look for precordial bulge, Harrison sulcus, vitamin D deficiency. Just now I mentioned can present. Of course, VSD, severe VSD can have Harrison sulcus like feature. Chest retractions, pallor, goiter. Pallor is also another important cause to be considered as a cause of failure. Fundus examination is very important, and ocular examination like Marfan syndrome will have subluxation of the lens, and then of course you will find evidence of other features of conditions. The child is having other ocular abnormalities. There can be colobomas, etc. There can be cardiac defects. Next one. 3 good vital practices. Place both palms on either side. I already mentioned. Next. Touch both feet for local temperature, both dorsal spidis. In Tuncus arteriosus, especially mild cyanotic heart disease, you find child is having a well-felt dorsal spidis, it's Tuncus arteriosus. We can almost take it for granted that is, and you will be correct 70% of the times. Always check all pulses and BP before proceeding to the rest of cardiovascular examination. Next. Arterial pulse and blood pressure. Asymmetric pulses, coagulation of aorta, I just now mentioned. The child had, right radial pulse was jerky and it was 10 millimeters. That was jerky and more. But the left upper limb pulse was less prominent. So naturally there was a difference, and it was the supravalvular aortic stenosis, and there were features of Williams syndrome. Signs of excessive aortic runoff like PDA, aortopulmonary window, AR, large systemic AF, all the signs. Usually in aortic registration, they'll ask what are the various signs you look for. Low volume pulse, aortic stenosis, low cardiac output states like cardiomyopathy. Viscerience pulse, hypertrophic cardiomyopathy, and then AS, AR, severe AR. Viscerience pulse will be present. Upper limb hypertension, coarctation of aorta. Of course, tachyosis, this also must not be forgotten because it's becoming more common, especially in a girl, in a pre-adolescent, adolescent. Always feel the pulses. And of course, nowadays echo is there. You can find out by echo whether there is, and angiogram is there to find any artery stenosis, the renal artery stenosis. Radiofemoral delay and radioradial delay, I already mentioned about that. Yes, next. JVP is very important, must not be considered as redundant examination. But if the JVP is prominent, if you find all the 3 waves, especially if you find Cannon A waves, it may be a complete heart block, or you will find the child is having severe tricuspid regurgitation, okay, or tricuspid atresia. Prominent A wave is present in pulmonary arterial hypertension and severe pulmonary stenosis. Okay. And A is equal to V, that is V wave, anesthetic ASD. The importance of pulses, paradoxes, and evidence of JVP in constrictive pericarditis. Cannon waves will be present in congenital heart block because the different rates, atrium is contracting and ventricular, so there is no sudden Cannon waves will be there, irregular Cannon waves. Prominent VY collapse in severe TR and Epstein's anomaly, elevated mean JVP, heart failure. So in an older child, of course, JVP must be looked for. And of course, sometimes it will be able to, if you really make it a practice to see JVP in children, it's not that difficult to identify the waves. Next. Inspection and palpation of precordium. Precordial bulge, left to right shunt lesions with significant shunt. So definitely there will be a precordial bulge, and there may be Harrison sulcus also. Cardiomegaly with left ventricular, these are the 2 conditions we have to think of: large post-ictal shunt in a younger child and LV dysfunction due to cardiomyopathy, or regurgitant lesion at mitral valve aortic regurgitation. Cardiomegaly with RB type, pre-tricuspid shunts, as I mentioned just now, pulmonary arterial hypertension, severe tricuspid regurgitation and pulmonary regurgitation, which is not that common, severe pulmonary stenosis with RB dysfunction. Yes, next. Inspection and palpation of precordium. Hyperdynamic apex, These are the three conditions which you must always try to consider and rule out. VSD, PDA, MR, and of course the presence of trill will tell you what is possible. And suprasternal pulsations and pulsation in the second pulmonary space and continuous murmur is PDA. So MR, of course, you know where the murmur is well heard and how it's conducted. Heaving apex means definitely aortic stenosis with low volume pulse, arterial pulse, and LV dysfunction in cardiomyopathy. Then asyndrotic congenital heart is prominent pulsation, left second intercostal space is always secondary to pulmonary arterial hypertension. We must try to diagnose much earlier than that. And LTGA, which is not that common, okay, but anyhow, we have to consider as a possibility. Then, of course, trill will always be present in small VSD, restrictive VSD. Once the pressure is equalized, large VSD may not get. And trill in left second parasternal space is subpulmonic VSD or VSD with PS. Trill left third and fourth parasternal space is muscular VSD. Prominent RV parasternal pulsations along with this thing trill, you have to think of a right ventricular outflow tract obstruction and pulmonary arterial hypertension. In pulmonary stenosis, large PDA and AS and murmur, you will find evidence of conditions. These are conditions where you will find definite heave, etc. So you have to look for evidence of palpation is very important. PDA, I told you, suprasternal pulsation will be present and trill will be present. And of course, you have to rule it out from venous sum. Next one. Auscultatory clues for underlying heart disease. Wide and fixed S2. You know why a fixed S2 occurs in ASD. So if you understand that fixed A2 occurs S2, you can even diagnose very early in life. Okay, because there is this is usually seen after 3 months of age. Once they say, right ventricular compliance becomes more and there is enough blood flow from the left atrium to right atrium, and then you will find there is a fixed S2. And ejection click will be seen in valvular stenosis of either aortic valve or pulmonary valve depending upon the area. And auscultatory members, of course, all of you know that loud outflow ejection murmur in aortic and pulmonary stenosis, soft outflow ejection left to right shunts, pansystolic murmur, we already mentioned VSD, MRTA, continuous murmur, PDA, venous sum should be ruled out. The other causes like dissecting aneurysm and all in Marfan syndrome, that is not that common now. Then my mid-diastolic murmur, mitral valve, large post-tricuspid shunt, and tricuspid mid-diastolic shunt, large pre-tricuspid shunt, and aortic early diastolic murmur is an aortic regurgitation, bicuspid valve. So it's very important that bicuspid valve, there will be a click in this case, and you will find aortic regurgitation. Just like mitral valve prolapse, you will find a late systolic click and there will be a systolic murmur. So late systolic murmur, you have to consider that whenever the child is lean and thin. Pulmonary area, pulmonary regurgitation, severe PAH. We must try to diagnose these cases earlier so that they don't go into reversal of shunt, Eisenmenger syndrome. Next. First short sound, loud mitral valve collapse, and of course will be accompanied by a mid-systolic click and rheumatic mitral stenosis, not congenital mitral stenosis. Congenital mitral stenosis was the fused cusp, so you will not find that. And Epstein's anomaly, multiple sounds will be heard. And soft S1 is PR prolongation make it soft, and LV dysfunction cardiomyopathies. Then calcific mitral stenosis will not make it loud S1. Conditions that affect audibility of heart sounds, like pericardial effusion, cardiomyopathy, etc. Next. Second heart sound importance, wide fixed split is very important, large ASD. Once you can appreciate that, both in inspiration and expiration, it's wide fixed split. Okay, Oscar in sitting position, lying down position. So you can diagnose definitely ASDs, most of the cases, even in as early as 1 year of age. Wide varying split. And of course, nowadays echo is available immediately, you can find out whether you can confirm your suspicion. Wide varying split in severe MR, early aortic valve closure, and late pulmonary valvular closure is large VSD without severe PAH. Then atrioventricular canal defect again without severe PAH, severe PS, We already mentioned these conditions. Next. I think it is 8 o'clock. So paradoxical
Yes,
split.
sir. Sir, how long will it take?
So I think I can this thing, I have a few more slides. I will avoid that X-rays and ECGs. Okay.
Yes, sir. Yes, sir.
Clinical findings because they must have seen so many ECGs and X-rays. So I will avoid that. Okay.
Okay,
Second
sir.
ultrasound is very important, as I already mentioned. Okay. Large PDA severe AR left bundle branch block will have paradoxical split. Okay. So you will find that the aortic sound will be heard earlier and pulmonary second sound will be heard later. Okay. Narrow splitting is, we have already mentioned, severe aortic stenosis, pulmonary arterial hypertension. Single second sound, simultaneous closure, VSD with pulmonary vascular disease, including Eisenmenger's. Again, Eisenmenger's due to atrioventricular electoral defect. Inaudible closure of one sublingual valve will cause severe valvular aortic stenosis or pulmonary stenosis. Next. Third heart sound means excessive blood flow across the pulmonary valve. Post-tricuspid left directions more than 2:1, severe MR, hyperdynamic states, or LV systolic dysfunction. Then you find RVS3, excessive blood flow across tricuspid valve, pre-tricuspid left directions. So S3, of course, can be normal in a small child, so much importance cannot be given at this young age. Next one. Fourth heart sound. Whenever you find fourth heart sound, we have to think of severe AS, severe coagulation of water, and restrictive left ventricular filling. Right sided SO, if it is heard, that means it is pushing and with difficulty, severe pulmonary stenosis. So very rare to hit, but you can appreciate sometimes SO. And of course, nowadays phonocardiogram can be done to find out that, but usually clinically you'll be able to make out. Next one. Ejection clicks. Well, I myself have a mid-systolic click. Okay, I have mitral valve collapse. In my family, this thing many people have, my father's side. So whenever you find ejection click in a small child with the family history, you must immediately try to do, and you will find so late systolic click or the systolic click in mitral area, and if the child is thin and lean, you look for mitral valve collapse. Constant ejection clicks will be heard in severe pulmonary arterial hypertension, idiopathic dilatation of pulmonary artery, aortic ejection clicks, bicuspid aortic valve. Yeah, we had a case with endocarditis. Then I found a click in the rounds and told immediately do echo. There was a bicuspid aortic valve and vegetation was there. Aortic dilatation, TOF and VSD also can have aortic ejection clicks, which already all of you know. Truncal level persistent truncus can cause ejection clicks. Multiple sounds will be heard. Next. Mid-systolic click, mitral valve collapse and tricuspid valve collapse. Multiple clicks absence anomaly. 4 sounds will be heard. Splitting of first heart sound as well as second heart sound as well as clicks. Next. Remember, realize it is worth investing, equipping yourself with a quality stethoscope than costliest mobile phones. I think I'll stop here, sir. So this is the clinical,
Yes, sir.
of course,
Yeah.
radiology and ECGs I have mentioned. Okay, so
Yes, sir.
I hope with case scenarios I could have mentioned. I have mentioned briefly some of the cases I have seen and I have diagnosed myself. So later confirmed by investigation. Those days we didn't have sophisticated ultrasound, etc. Later only we got it. So it's very important that you learn clinical medicine at the bedside and then try to diagnose and then confirm it by modern investigative facilities. Thank you very much, sir. I thank you for this opportunity given to me.
Thank you, sir. Thank you for that revision. Thank you
These
very
slides
much.
can
And
be given to all of them, sir. All the
Yes, sir.
students who are attending.
yes, sir. So
They can-
with that, we
they can
end
go to
today's
other-
class. So thank you all our online viewers. Thank you the faculty online. And we meet once again next Thursday at 6 p.m. Thank you. Thank you.
I hope